So today I'll be presenting etiology and evaluation of galactorrhea. So first to define, it's non-pathologic nipple discharge unrelated to pregnancy or breastfeeding. So when you have nipple discharge, if it is anything other than milky, then you rule out breast pathology. So it can be mastitis or cancer. So you do a history and physical and a mammogram. Then we come to galactorrhea, which is milky nipple discharge. So when you have milky nipple discharge, the next thing to do is the prolactin level. If you have galactorrhea and a normal prolactin, you don't have to do anything else. But if the galactorrhea is so bothersome, you can give a short course of dopamine agonist such as cabergoline. Now, when you have an elevated prolactin with galactorrhea, then the next step is give cabergoline? No, you have to evaluate. Now, we are going to talk in detail about what do we do to evaluate and what are the things that can cause an elevated prolactin. Now, to brush upon basics, prolactin is secreted and released from the lactotroph cells in the pituitary gland. It is majorly inhibited by the hormone dopamine from the hypothalamus. And it is stimulated by, as Dr. Leela was saying, TRH, thyrotropin releasing hormone, and vasoactive intestinal peptide from the hypothalamus. So in the next slide, we'll see this picture where you see this lactotroph cells in the pituitary gland that produces prolactin. So if you have a prolactinoma, which is a pituitary adenoma secreting prolactin, you're going to have a high prolactin. And you can also have high prolactin from a non-functioning adenoma or a growth hormone secreting adenoma, which can also produce more prolactin. And then estrogen stimulates prolactin, but not to a very high extent. So if you're giving oral contraceptives, you can only have very little elevated prolactin. So oral contraceptives alone cannot be a cause of elevated prolactin. And then we go to dopamine. We know dopamine is the hormone that inhibits prolactin. So anything that decreases dopamine is going to cause an increased prolactin, such as medication. So antipsychotic drugs are known to cause decreased dopamine by blocking the D2 receptors. And there are some antidepressants that can also decrease the dopamine. And then if you have a chest wall injury, like Dr. Leela was presenting, then through autonomic nervous system, you can decrease the dopamine, thereby increasing the prolactin. And then when you have a problem here, like hypothalamic pituitary stalk problem because of suprasellar lesions or infundibular lesions, or if you... Oh, is it? Okay. So then if you have stalk damage because of head trauma or if you have, surgery, then there is a damage to the stalk, you can have an increased prolactin. And then we go to what elevates TRH. If you have uncontrolled hypothyroidism for a long time, that can also increase the TRH, and that can also increase the prolactin. And then finally, when you have reduced clearance of the prolactin because of kidney disease or liver disease, that can cause an increased prolactin. So these are all the main things that can cause an increased prolactin. Now, what do we do when we have galactorrhea or elevated prolactin? The first thing to do is a detailed history and physical, because with the history and physical, we get a lot of etiology and we know where it is coming from. Now we know what are all the things that can cause an increased prolactin. So the first thing to rule out is pregnancy, last menstrual cycle, how are the menstrual cycles, and all those things. And then to look at the medication history in detail. And then if they have a history of hypothyroidism, depression, and do they have kidney disease, and then examining the patient to see if they have signs of chiasmal compression, like visual field exam, and then history of chest wall injury. So what are all the lab tests to order? Now, Endocrine Society guideline just recommends a single prolactin. But then there are some body of evidence, small body of evidence saying You repeat a fasting prolactin because meals can increase the prolactin to some extent. So you can always do a repeat fasting prolactin. And when you're doing a repeat fasting prolactin, just do it in 15 to 20 minutes later than the first one to exclude the possibility of pulsatility. And then you do a HCG to rule out pregnancy, and then TSH, you do a kidney function test. If you have a pituitary adenoma or a supracellular tumor, then you do all the pituitary hormones such as IGF-1, cortisol, free T4, FSH, and LH. So when do we do a MRI SELA? The guidelines recommend us to do MRI SELA if the prolactin is more than 100. Now, I had a patient whose prolactin was 92. I did not find any obvious reason. Then I did do a MRI SELA. So it's more of a clinical judgment rather than a number prolactin of greater than 100. Now, we have 3 patient profiles here, all 3 presented with a high prolactin and or galactorrhea or irregular menstrual cycles. We'll see how these 3 cases presented and how did we evaluate and manage. So the first one is John, who is a 22-year-old obese male. He presented to the primary care because he couldn't grow a mustache. There was a gap in his mustache. So the primary care neatly did all the blood count and then kidney function. They did a thyroid that was normal. They also did a testosterone because he also had very low energy and erectile dysfunction. So the testosterone in a 22-year-old male, you would expect that to be like, in the range anywhere from 400 to 900. But his testosterone was 81. So then they referred the patient to us. We checked the prolactin. It was 1,200. Then we did a history and physical. He does not have any other medical history, no medications. So we do a MRI brain, and he has a 1.5 centimeter cellular mass. And we did all the pituitary hormones, and we also did a dexamethasone suppression test to rule out Cushing's, which is a cortisol co-secreting tumor, and that was also within normal limits. So what we have is a pituitary macroadenoma secreting prolactin, which we call as a lactotroph adenoma. Now, about lactotroph adenoma, these are the most common pituitary adenomas, comprising like 30 to 40% of the pituitary adenomas. Now, usually the size of the tumor correlates with the prolactin concentration. So it can cause prolactin elevation anywhere from 50 to 50,000. So say if you have a microadenoma, which is a less than a centimeter tumor, the prolactin level is usually less than 200. But if your prolactin level is more than 200, it's most likely you have a macroadenoma. If it is more than 2 centimeters, the prolactin level is more than 1,000. Now, when you have a big prolactin secreting tumor and it doesn't correlate with the prolactin number, you can ask for a diluted prolactin, which can eliminate what is called a hook effect, where you have high prolactin and this gets saturated. So you can ask for a diluted prolactin when you are thinking of a pituitary macroadenoma secreting prolactin, but the prolactin is not that high. Usually the cases are sporadic, but it can also occur as part of MEN1 syndrome. Now, what did we do for John? We started him on cabergoline, 0.25 milligram twice weekly. And over 9 months, cabergoline was gradually increased. Now he's up to like 1.75 milligram per week. The tumor has reduced to like 4 millimeter, and testosterone has come up. He could, get a big mustache with the beard, and prolactin is suppressed. So our plan is to continue the cabergoline for some more months and then repeat the MRI until he'll be on cabergoline until the tumor disappears, if we can achieve that, and then probably wean down and then stop. So then we have the next patient, Sitara. She is a 35-year-old female with history of secondary amenorrhea for 4 months. She also has galactorrhea. She has a history of schizophrenia. She's on risperidone. Now, the psychiatrist checks a prolactin, which is 82, and thyroid function tests are within normal limits. And she also had ultrasound abdomen pelvis, which was normal. And the patient was referred to us, and we repeat a fasting prolactin, and it was 131 in 2 weeks. So this is a typical case of drug-induced hyperprolactinemia. So usually the prolactin increases within like hours of starting these antipsychotics, and then it returns to normal within like 3 to 4 days of stopping. Risperidone is known to cause high prolactin, and usually, on an average, it can cause from 45 to 80, but it can also go up to like 200 or 300. And then among the first generation, Haldol is the one which can also raise the prolactin very high. The newest antipsychotic, amisulfide, I see that it's being used more commonly now, and that also causes a highest elevation. The one thing to remember is that topiramate, among this, which is used for psychosis, has an inhibitory effect on prolactin. Now, here is a big list of antipsychotics which can cause prolactin elevation. Among them, as I said, Haldol, the first generation, Haldol and flufenazine causes the highest. And then second generation, we have risperidone and paliperidone, which causes the highest. And then these are the other drugs. Antidepressants, not many of them cause high prolactin, except clomipramine causes a high prolactin. And then the one thing that I see commonly is that people are given pantoprazole along with domperidone here in India for heartburn, and domperidone can cause a very high prolactin, so we have to keep that in mind. And then also opiates can cause. Now, what did we do for Sitara? We discussed the case with psychiatrist, and then we asked if risperidone can be substituted with some other drug. And we know aripiprazole. Aripiprazole is an atypical antipsychotic which has both dopamine agonist and antagonist property. So the psychiatrist said, yes, definitely we can try. So this patient was switched to aripiprazole, and the prolactin dropped to 30 within a week. So if that is possible, you can always discuss with the psychiatrist. The first thing is to discuss with the psychiatrist, see if we can switch it. So if we cannot switch it, should we start cabergoline? No, because cabergoline is dopamine agonist. So it can worsen the psychosis. So that we definitely need to know. And so what do we do with these patients where we cannot substitute this antipsychotic? So if they're asymptomatic from hyperprolactinemia, say if a woman with drug-induced hyperprolactinemia has regular menstrual cycles, no galactorrhea, then you don't have to do anything. But if they are symptomatic with absent menstrual cycles and or galactorrhea, you can definitely give estrogen, to treat the hypogonadism in a women, and testosterone in a men with hypogonadism. So this is another patient to our clinic. She's a 26-year-old female, Simran, history of glioblastoma, which is stable. She also has mild depression, not on any medication. She has a history of migraine. She had irregular menstrual cycles, so her gynecologist checks all these hormones, including thyroid, FSH, LH, and then prolactin. Prolactin was 91, so she was sent to us. Her medication list has had only one medication, which is flunarizine. I did not know much about this flunarizine. So she said it was given by her neurologist it's a calcium channel blocker. We Googled and we saw it's a calcium channel blocker. And then we did some PubMed research, and looks like flunarizine can cause an increased prolactin by acting on the dopaminergic system as well. So we discussed with the neurologist, and we asked, can the flunarizine be decreased or switched to another thing? So he decreased the flunarizine to just half the dose, and the prolactin went from 91 to 50. And then again in 2 weeks he switched it to some ergot derivative, and then the prolactin went down to 25. So we definitely have to, look at the medication history. We have to PubMed to see, if these drugs are causing the high prolactin before when we have a high prolactin, our reflex is to give cabergoline. I think we have to take a pause, to look at the medication history, and then just double check if that is not coming from there. Now, going to other causes, any diseases or tumors in the hypothalamus, if it affects the dopaminergic neurons in the hypothalamus, is going to cause high prolactin, like craniopharyngiomas or metastatic breast carcinomas, or if you have infiltrative diseases such as sarcoidosis in the hypothalamus. And then we talked about head trauma or surgery affecting the stalk, and then any adenoma of the pituitary, other than lactotroph adenoma. And then these are the other causes. We talked about all of it. The one thing I want to point out here is macroprolactinemia. Now, usually the native form of prolactin is smaller in size. It's 23 kilodaltons in size. Now, this macroprolactin is an aggregate of prolactin and antibodies, and this is like huge. It's like 150 to 170 kilodalton. This is called a macroprolactin, and most of the labs can do this macroprolactin for you. So what do? They just pre-treat the serum with polyethylene glycol, and then they can assess the macroprolactin. So the beauty of this macroprolactin is that they are detectable as prolactin, but they do not cause any symptoms because they are biologically inactive. So if you have a patient with asymptomatic hyperprolactinemia, they checked prolactin for something else and the prolactin is high, and the patient does not have any symptoms, please do check for macroprolactin before we start treating with cabergoline. So this is a graph which illustrates the prolactin concentrations and the etiology. So as we discussed, if the prolactin is more than 200, you got a pituitary macroadenoma, unless the patient is on risperidone. Okay, and then if the prolactin is between, say, 50 to 200, it can be a pituitary microadenoma, it can be drugs, hypothalamic disorders, so we have to see what causes it. Now, in summary, and the guidelines, what do they say? In patients with asymptomatic hyperprolactinemia, check for macroprolactin. And exclude, the first thing I would exclude is pregnancy, and then renal failure, hypothyroidism. Look at the medication history in detail. If they are on antipsychotic, please discuss with the psychiatrist before we start them on cabergoline. And as far as possible, please don't start if they are already on antipsychotic with a dopamine agonist for drug-induced hyperprolactinemia. And discuss the antipsychotics with low dopamine antagonist potency with the psychiatrist. If we cannot substitute, then we can always think about estrogen or testosterone in patients with hypogonadism. Now, I didn't talk much about treatment because the topic was etiology and evaluation. Just to say about the dopamine agonist, we like cabergoline because it has lesser side effects, more potency than bromocriptine, and more potency in the sense it lowers prolactin better, as well as it shrinks the tumor better than bromocriptine. So we like cabergoline. Thank you.